Hey everybody, I'm Robert Brady. I'm one of the surgeons over at Points East, along with Dr. Elizabeth Taylor, who will be giving our talk tonight. A little bit about Dr. Taylor, you didn't know, is she's actually board certified in both large and small animal surgery. She spent the first part of her career working primarily with equines, and then switched over to the small animal world in the past couple of years. She's been a great addition to Points East and brought a lot of intuitive ideas, and she's been a great person to work with. She has a couple of dogs, one she rescued from Points East, Roger, who's a little bit of a special needs fella. And then she's got another one named Boris, who's a Frenchie, and he's been through some hard times lately, but he's got his eyes back on track. And when she's not busy surgerizing pets down at Points East, she's likes to spend some time with her recent husband and her two dogs, Boris and Roger. And when she can, she likes to get out to the beach, just like the rest of us for the most part. So this evening, she's going to be talking about lameness and the dog, primarily associated with things not the cruciate. So most of the time it is cruciate, but every time now and then it isn't. So she's going to kind of walk us through some ways to figure out whether it's a cruciate or not. So if y'all have any questions, feel free to use the chat feature. We may save some of those questions for the end, or we may talk about them during the presentation, depending on how things are going. So without further ado, here's Dr. Elizabeth Taylor to talk about lameness in the dog not associated with the cruciate.
Hi, everybody. Thanks for joining us today. I just wanted to, and thank you, Robert, for that introduction. I do love my two dogs, and you'll see them today in the presentation, some more cooperative than others. But just want to welcome everybody to the start. I want to thank Matt, who is our audio guy, has been doing a great job. And so first off, we will start with a polling question, just about how comfortable you guys are performing a complete orthopedic exam. So are you guys very comfortable? You perform them all the time? Are you moderately comfortable, minimally comfortable, or would you prefer not to do them at all? Would you prefer any and all ortho and or lameness? So Matt's gonna take that poll and let me know the answer. And while you guys are kind of talking about this or thinking about the answer, I think most everybody is pretty comfortable with an orthopedic exam and diagnosing the cruciate ligament. It is by far the most common lameness that we do see, especially in our hospital, but it tends to get a little bit trickier when it's not the case. So today we're just going to kind of discuss some of those things that you may confuse with a cruciate ligament rupture. Some of them are pretty obvious, but others can be a little bit tricky. So now I see most of you are moderately comfortable, which is great. And that's awesome. You know, I think moving along, we can change that slide there, Matt, to the orthopedic exam. I do think that some people get overwhelmed with an orthopedic exam, but it is just like anything else. The more you do, the better you are going to get at this. It really shouldn't add too much more time to your physical exam in general. I kind of work it into mine. First off, it's that history. That signalment and history is going to be key. Subtle things in these cases like age and acuteness of injury, these are going to tend to lead you one way or another. And as we go through a couple of these other things, that will be a little bit more apparent. Second off, observation, also very key. This can be done as you walk into the room. I tend to look at the patient at this point. Do they seem to be favoring one leg over the other? Are they looking a little ataxic? How mentally appropriate are they? Those sorts of things before you really get into the meat of your exam. I don't think that there is a specific order in terms of palpation versus gait evaluation. Sometimes I will do gait evaluation before, palpate, and then do gait evaluation after. It's just one of those things. I think for me, a lot of my background is horses, and horses love to be lame. And so I actually love a lameness evaluation and gait evaluation. I think we do get a lot of tips from these. my technicians always laugh at me because I'm always saying one more time, take them down and back one more time. And, I want to evaluate how they're standing, and I want to evaluate how their foot is hitting the ground. I want to evaluate is their muscle wasting, how severe, where the lameness is, all of those things. And so I don't think you can watch them walk enough. Sometimes if it is even a very slight lameness, I will go ahead and take them outside on more solid ground to see if that changes anything. Again, with your palpation, palpating all the joints for a fusion, palpating any sort of lump or bump. I think too, remembering the gait evaluation about the down on sound. I think for owners, sometimes they confuse us in this instance, and just making sure that you guys are on the same page in terms of what leg you guys are evaluating. And then I think it is just because there can be sometimes a blurred line between a neurological syndrome and an orthopedic syndrome, is to work some of those basic neurological exam things in. So, ataxia, looking at their nails, are they dragging their feet? Sometimes those can give us a little bit more insight into this. So a good orthopedic exam is very, very important. And so here are just a couple pictures. Matt, you can go to the next slide, of me performing. This is Boris, his first cameo. And so here I'm just doing a lot of this while the animal stands. Even in a big dog, I typically try to do them in more their normal stance. So I extend the legs here from the hind end, again, palpating all of those long bones, and especially the joints for a fusion. Here is a video of me performing the cranial jaw. Now I understand that this is not the topic of this presentation, but if you can see in this video, I am placing the forefinger and the thumb of the left hand on the patella and the fibula, and then the thumb and the forefinger of the right hand on the fibular head and the tibial tuberosity. And so this allows you to have that complete control over this. Now, Boris thankfully doesn't have any cranial drawer, so there is a little bit of motion in this joint, as you can see, but what you do notice is that motion does stop. Additionally, I'm evaluating him for thrust. I think this is sometimes a little bit more tricky for people to evaluate, but all you're doing in this is just kind of placing their foot in a what would be a standing position and evaluating that translation of that tibia forward. So that is him in all of his glory. And again, this is just evaluating for a patella luxation. I really crank. I'm also feeling for a little bit of a fusion here. So I put my fingers on either side of that patella ligament, and then really try to luxate that patella. So want to put that leg in full extension and really try to crank on it. And Boris does have grade 1 patellas, but over the years, I think that's actually gotten better. Here is another video. This is how to perform an Ortolani sign, obviously while evaluating more of the hips. I tend to perform this exercise in lateral. It is much easier and recommended to perform this while the dog is sedated. I did not sedate Boris in this, and he is a little bit resistant, so we give him that. But typically how you're going to perform this is by placing a thumb on the greater trochanter, and then you're going to apply a little dorsal force to the stifle. This is actually a measure of hip laxity. And so you want to make sure, if you see here, I keep kind of shaking his leg and holding his hip in the normal location, just to kind of relax him. And then as I apply that dorsal force to the stifle joint, this is going to cause a little bit of subluxation, okay? And then what you want to do is you abduct that limb. And what you're listening for is a click, or you're feeling kind of a drop. And so if you hear and or feel that, that is a positive Ortolani test. If you don't and it's negative, that's fine. That's great. It is a measure of that hip laxity in terms of diagnosing that early hip dysplasia. Alternatively, I think some people were trained by performing this in dorsal Boris was definitely not cooperative for this one, so I don't have a good video. But again, you can kind of apply that force dorsally to both of those hips as you adduct that limb. So in terms of a good orthopedic exam, those are kind of the main things to think about. Again, very, very important and something that we do every day. And so next slide, Matt. The outline for this presentation is we are going to work through some of these more commonly diagnosed things that are not cruciate ligaments. And I am going to work through some of these in terms of trying to distinguish which from which, just because we do sometimes get some referrals. And again, it is very easy, and there's plenty of examples in this presentation about how we can get some tunnel vision when it comes to the hind end, and I do it as well. And so I'm going to work through joint by joint some of the things that can be confusing in addition, or when thinking about cranial cruciate ligament disease, but then diagnosing those things that are not. So we will start with the stifle. We'll then move into the hip, the tarsus, and then there's just a couple things. Actually, I think it might just be one thing in this miscellaneous category that sometimes can trick you up. This is by no means an exhaustive list of things that can happen in the hind limb, but again, just to give you an idea. And Dr. Harrington is actually going to be manning the chat, so please feel free to ask questions. If it's really pertinent, she will interrupt and we'll get that answered for you. Otherwise, we'll definitely have some time at the end, okay? So next slide. So we will start with the stifle. So I think most of the main things in the stifle that can get confusing and trip you up, I would say number one by far is the patella luxation. We're going to go in medial versus lateral patella luxations, a little bit of pathophysiology and treatment as well. We'll then kind of move down the list, talk about collateral ligaments. I would say this is more in conjunction with a cranial cruciate ligament disease. So just something to keep in mind, that sometimes it's not just cranial cruciate ligament, that there are some other ligaments involved. We'll move on to the caudal cruciate ligament. Again, this is pretty unlikely. I have only seen 2 of these cases in my career, so not very common, but just some things to have on your differential list. And then lastly, patella fractures. Again, something that's probably going to be a little bit easier, an easier diagnosis based on kind of presentation and location of swelling. So we'll go to that next slide. So let's start with patella luxation. Everybody loves it. So we most commonly think medial patella luxation in small dogs. This report, it's an older report, 1994, but pretty much most of these are developmental abnormalities, okay? So we think about our small dogs, our Pomeranians, our Yorkies, and our Chihuahuas probably, but there's plenty of other animals that we get medial patella luxations in. So again, these dogs typically have a shallow to absent trochlear groove. They have a decent amount of coxovera. That typically causes a little bit of bow-leggedness. They also can have hypoplastic medial trochlear ridge. Again, kind of, you know, baiting that patella to move more medially. And then oftentimes they have quite a bit of internal rotation. And this, I think, is sometimes where we can get tripped up in our diagnosis, because a lot of times with that internal rotation, that joint is a little bit lax. And so you can get a little bit of movement, sometimes making you think that there might be a little bit more cranial drawer than there really is. We can go to the next slide. So this is just a little video, cute little, very classic breed, small, probably terrier mix, but a very classic gait of these patella luxation. So very intermittent skipping. I would assume that this dog would have a grade 2 patella luxation. We will get into that in just a few slides. But just to give you an idea of what this typically looks like. We'll go to the next one. Again, when you go to radiograph these guys, This is a pretty classic radiograph. And again, this is where it can get a little bit confusing. This was an 11-month-old golden doodle, something of that nature, but it was referred for a CCL injury. This dog had some intermittent lameness that was becoming more consistent. And so for me, when I hear this presentation, an 11-month-old golden doodle kind of intermittent lameness, for me, the first thing that pops into my head is that this dog is just a titch too young for a cranial cruciate ligament rupture. Now, not to say that it can't happen, it absolutely can, but most often those cruciate ligament ruptures are going to be in a little bit of an older dog. So I typically kind of have this internal like 18 month to 2 year cutoff where I really then switch to it being more of a cruciate ligament than of a patella. But if you can see in this joint and not on that lateral radiograph, there is quite a bit of a fusion. Again, and that can be a sign of cranial cruciate ligament, but also can be a sign of this patella luxation. And you can click to the next picture radiograph on there. And then this is the more classic radiograph that you guys see. Definitely that patella is moving more toward the inside, the medial aspect of that femur. Than it is in the middle. So clinical signs on this dog, I would say again, 11-month-olds, it's where you're going to be in this puppy drawer type area. So the hard part about, we talk about puppy drawer, and I don't know how familiar you guys are with this, but pretty much all young dogs, their ligaments are a little bit more laxed. And as we get older and develop more muscle, things tend to tighten up. And so puppy drawer is just a little bit more laxity within that joint and in that ligament. And so I think a lot of times this can be confusing, and specifically in this case. So palpation, there was definitely motion in the joint and internal rotation, again, going back to that internal rotation. So the joint was overall movable. However, it had a stopping point. And I think that's a little bit of the difference between typical cranial drawer that we talk about in dogs that have ruptured their cruciate ligaments versus those dogs that have that puppy drawer or just that laxity, as that motion does stop. So there is a stopping point. That tibia does not translate as far forward. And so this is just a good example, something to keep on your radar when working through these cases. So again, a little bit of a younger dog, and then just be careful of that internal rotation and then that laxity in there to kind of throw you off. But this dog definitely had more medial patella luxation when we ended up doing surgery on going into it. It had a beautiful cruciate ligament. So go ahead and go to that next slide, Matt. So we'll kind of move forward a little bit for patella luxation in the medial patella luxation in the large dogs. I would say in general, overall, this is largely misunderstood as even our profession as surgeons. I think we see this incidence increasing. It's been reported that, early on, I guess way back when in the 70s, it was kind of a 15% incidence, and now it's actually increasing to about 40% in these large breed dogs. And I think that definitely has, probably is reflective of our population. I think we have a lot of more mixed breed dogs, maybe some with some pit bull in them that tend to have that bow-legged look to them. So I think that probably is the reason why we have seen an increase in incidence in this. This is probably, I would say, the most commonly misdiagnosis of a cruciate ligament. And again, it's for those aforementioned reasons, is that there can be a lot of internal rotation in these dogs. And then again, classically, when we think about cruciate ligaments, we think about those larger really active dogs. So I think this is the one that we need to be a little bit more careful about. These dogs can have a shallow trochlear groove. I would say surgically, much more commonly, it's a lot of times it's more so the internal rotation that causes these dogs to have the patella luxation more so than the shallow trochlear groove. I find that to be a little bit more common in those small dogs. Again, I would say younger dogs, we see this. So those younger labs or pitties that have that intermittent lameness, again, probably 18 months and below, this is where I start to think, hey, this might be more of a patella luxation than it may be a cruciate. So just something to kind of keep on your radar when being presented with these cases and these lamenesses. We can head to the next slide, Matt. And here's lateral, pretty much it's the same, but it's the opposite. So instead of those coxoverum, we have coxovalgus. So you think of valgus, so an outward rotation, same with the tibia as well. And oftentimes they have that external rotation. I would say lateral patella luxation, much more common in the larger breed dogs. Pretty uncommon for us to see them in the small breed dogs. There can be oftentimes a bidirectional component. I'm actually dealing with a couple of these cases right now. I would say lateral patella luxations tend to be, for me, a little bit more challenging surgically. I don't feel like, I tend to think that they are even a little bit worse at presentation, and so thus harder to really get back to a more normal gait. And you'll see a case here coming up in just a little bit. And so we can go, everybody loves a good grading scale. Matt, you can come to that next slide. And so when we talk about patella luxation, this is the grading scale that's widely used by surgeons. I think, sometimes we take some liberties, and even in myself, I'll probably sometimes call it a 2+, which, is not always great, but definitely trying to stick to this grade for us when you refer is great, just so we kind of know what we're getting into and kind of the recommendations moving forward with surgery. So usually that grade 1, it can be luxated at full extension only. Maybe it doesn't even luxate fully. Maybe it doesn't even cross over the entire medial trochlear ridge, but it does kind of have some movement within that groove. Typically no bony deformities are present, and then the animal is not clinical. Grade 2, more so like that video that we saw. So it's that spontaneous luxation. You get that non-painful skipping type lameness. You can have mild deformities present when you do radiograph these guys, but overall pretty intermittent. I think that's probably the hardest grade, and we'll kind of go into this a little bit in the next couple slides to determine whether or even if to perform surgery on those. Grade 3, the patella is permanently luxated. It can be reduced manually. We do see some more severe bony deformities. They can have a little bit of a crouched gait. Oftentimes they can be bilateral at this point, again, really hammering that congenital component. And then we have the grade 4, and this is severe, permanent, non-reducible luxations. They typically have severe rotational abnormalities and are very, very challenging to treat. Majority of your cases are definitely going to be in this 2 to 3 range. I think it's very abnormal for us to see grade 4s, again, although I'm treating 2 of them right now, so it must be my lucky month. But I often think that, once that patella has a pathway, it will continue to move. So oftentimes a grade 2, if let to continue to go and not really intervene with any rehab or anything, they will progress to a grade 3 at some point, thus necessitating surgery. This is one of the cases. You can head to that next slide, Matt. This is one of the cases that I'm dealing with right now, and you can see that these these lateral patellas, you can see them way out. They're definitely just not in the same zip code, area code. They're not even close to where they need to be. And this is actually it's a 6-month-old Great Pyrenees puppy. I think combination of probably some congenital malformation, but in addition to that, I don't think at this point it's a rescue. I don't think it was able to stand much. And so this is one that we are, I would grade a grade 4. They're definitely non-reducible even when the dog is sedated. So again, very challenging case, probably very, very extreme, but just so you have an idea of what that grade 4 kind of looks like. Go ahead and we can move into treatment. You can move to the next slide, Matt. The decision to proceed with surgery, as I was saying, is a function of the grade and the timing. And it does differ, I think, between veterinarians. And, you know, I think that most would say these grade 3s and grade 4s absolutely require surgical intervention. It's kind of this nebulous grade 2 that remains a little bit sticky. As I mentioned, sometimes in those early, really young animals that have a grade 2, sometimes I will recommend a little bit of rehab to try to strengthen those quadricep muscles, depending on how bad that grade 2 is, to see if maybe we can avoid surgery. But oftentimes we do end up doing some sort of procedure for those to stabilize it. I think timing of the therapy is really important. Oftentimes, again, these are congenital issues. And so sometimes the earlier we can intervene and make sure that these dogs have normal joints and normal forces acting on the rest of their joints, the better. However, when we talk about some of these treatments, we're dealing with animals that still have open growth plates. And so we really need to be cognizant of performing corrective osteotomies on dogs that still have plenty of time to grow. So I basically, you know, kind of have 2 different courses of action kind of based on the severity of these dogs. So in the dogs that have the lower grades and they aren't as severe, I typically tend to wait until skeletal maturity. So making sure that their growth plates are closed, typically about 11 to 13 months to do everything in one anesthesia. And so I will evaluate all of these treatment options at the time of surgery to determine kind of how far we have to go. In the animals, however, that are more severe, I do tend to do a 2-stage procedure. So we can often do the soft tissue aspects of this. And then if we need to, as the animal reaches skeletal maturity, go back and then do some more corrective osteotomies if necessary. So I think, you know, again, there are multiple treatments for patella luxations, and we'll kind of just briefly touch on these. I bet some of you guys do perform some of these in, I think, in general practice, which is fine. I think it does get a little bit more dicey when we do get into the tibial transpositions and things. I don't feel as though people are as comfortable with that. But just from the start, the trochleoplasty, most people know, the goal of this is to get 50% of the patella that protrudes above the ridges. So oftentimes it's more than that at the time of surgery. So we either do a wedge or a block. I would say for me, I prefer a wedge. They do make special saws for this. And I've really just used hobby saws as well. But kind of mark the area, and you can see here in this picture, this is a nice, beautiful wedge. Unfortunately, is not mine, but it does look quite lovely. In addition to that, we can go ahead to the next slide. In addition to that, typically you combine that soft tissue reconstruction at that same time if we're talking about these young animals with open growth plates. So typically the tissue is contracted on the side of the luxation, and it's lax on the opposite side. All of that makes sense. So what we do is we want to do a retinacular release. We want to release the tissue that is tight. And then we want to imbricate the tissue on the opposite side. And so in those medial patella luxations, you can release the tissue and then on the medial aspect, and then imbricate, on the lateral. Oftentimes in these kind of middle grades, I don't do a release. I only release the tissue when it's more in these severe kind of grade 4 cases, mainly because I think that I can, I don't like sometimes the amount of scar tissue that develops. I think you also increase your risk for seroma formation by just releasing some of that tissue. So I tend to focus a little bit more on imbrication than on release. From that standpoint. There's also the anti-rotational techniques, so a tibio-fibellar suture. There's also a fibello-patellar suture. Again, this is more so going after that internal rotation of these joints, and that does tend to correct some of these as well. The tibial transposition, again, something that you may or may not be comfortable with, but typically the goal behind this is to reduce that internal rotation. And so by kind of cutting that front of the bone and shifting that to the lateral aspect, we kind of shift this center of axis to that more lateral side, so everything is a little bit more in line. Typically for me, I do a combination of wires, depending on the size of the dog is when I typically add in a tension band. So if it's a pretty small dog, I will just do 2K wires. I would say probably about 20 pounds, and depending on the activity is when I would probably increase to adding that tension band of that. All of my big dogs will get a tibial transposition pretty much, and stabilization with those pins and the K-wire. Next slide. This is just a picture. So again, this was a staged, this was the dog from before with the crazy lateral patella luxations. And as you can see now in that right leg, we have moved the patella into a normal alignment. And in reality, once we've now done that, the bone itself actually has a decent straight line to it. So this was part 1 of stage 1 in this dog, with it being 6 months. And then we would move forward to probably doing stage 1 of the left leg as well after this. So this dog is still in rehab in our care and doing well thus far. We can go ahead and, and this is just a note. I will say personally, I don't do a ton of these corrective osteotomies in terms of the distal femoral osteotomies. They do require some special imaging. CT is really preferred for these. I think these are, this procedure is definitely reserved for those really, really severe cases. And this might be where, this lateral patella luxation is headed. But again, not something that I even typically perform in practice. When we get into patellas, I think the most frustrating part for me and probably for you is that it has a decent complication rate, and that's really across the board. All studies have shown that. It's challenging. We have a major complication rate of 20%. And I think those are kind of grouped into this implant associated, whether that K-wire breaks or migrates, and then reluxation would absolutely be at the top of the list. And when we talk about major complications, we talk about those complications that require a second surgery. Now, tibial tuberosity avulsion, I would say, is a little bit less. I think that largely has to do with your positioning of your pins. And I think with practice that can get pretty good. So again, this is just a more recent paper when we talk about that tibial tuberosity transposition. There's a 5 time reduction rate in that relaxation rate if we do perform that. And so I think, you know, again, this kind of goes to the point in that timing. So if we kind of wait these guys out, maybe try to do a little rehab, get their quadriceps stronger, but then are able to do these procedures when the animal is at skeletal maturity, the likely, if we do the transposition, we do get a significant reduction in that relaxation rate. And then just a note, again, kind of going to the tibial tuberosity avulsion, is that if you use 2 K wires instead of 1, you have much less likely to have that avulsion. And so that's typically what I do. Most of the literature, I think, is published on medial patella luxations. I think there is some on lateral. In terms of that complication rate actually is a lot higher, so more on the order of 40%. So just something to take into consideration when you guys are seeing these cases and thinking that maybe it might be something that you would attempt to do. We are always happy to see them for referral, especially with this relaxation rate. So that's kind of it. We can move to the next slide. For patella luxations, I don't know, Dr. Harrington, if you have any questions at this time before we move on, or if you want me to keep moving forward.
Yeah, no questions on the chat right now.
Okay, really busy. It's really busy.
And we can move to the next slide, I think, too.
Okay, great. So when we talk, we can go to the collateral ligaments, Matt. So the collateral ligaments provide angular stability within the stifle as it's in extension. And that isolated injury can be very challenging to diagnose. I think these animals are going to have more intermittent lameness than anything else, but they do require some stress radiographs and palpation to diagnose. Like briefly touched on before, I think that this injury is more common and more likely to be a problem, or missed rather, in conjunction with the cranial cruciate ligament. And so with this, typically the one thing that we do think about are deranged stifles in cats, okay? That is the main way that I have seen this. I've seen a couple of collateral ligament injuries in dogs in conjunction with the cranial cruciate ligament, but very few in isolation. If we do see them in isolation, typically we can manage these conservatively with a lateral splint for a few weeks, and then we kind of transition them into some leash walking for an additional kind of 4 to 6 weeks. And that treatment is typically very similar to that in humans. If you are to tear your MCL or LCL, that's how they would treat you as well. We can go ahead to this next slide. And this is more like what I was talking about before, is that deranged stifle, is when you get that cat, and this is probably the only cat specific thing in this talk, is that you see this deranged stifle where basically you don't know what's happening. You know that there is a lot of trauma, but we don't know what. And so it's that to make sure that we evaluate everything in this joint. It's not typically too challenging of a diagnosis, but it's just trying to recognize all the parts. So it's often a very unstable knee. Kind of as you go to palpate it, it moves in every direction. And so really for these, referral is the best option. So you want to be ready to explore the joint, evaluate the menisci, evaluate the cranial and caudal cruciate ligament, and then be able to potentially reconstruct those medial collateral ligaments if necessary. So we can go to the next slide. So that's just a little bit of that. I did kind of skip over in really explaining the caudal cruciate ligament. I think it's just something to have on our radar. But in reality, it happens very, very infrequently. And so not much research and not much help in terms of treatment and everything. I think most often what we would do is an extra capsular repair just to provide some stability. I think a lot of these dogs can be managed conservatively. So moving forward with patella fractures, again, rare. These are not something that you're going to see very common. They're usually traumatic in origin, and they have a little bit more localized swelling. So I think this is something that can be pretty straightforward to diagnose, and it's a very complete and acute fracture. I do have an example of one here. I was referred a case for a potential cruciate just based on the swelling. And I think the swelling there was some joint effusion, but there also was more local focal swelling at the level of the patella. So we can move on to the next slide. Typically for these, it does depend on the type and location. So you can have them at the apical portion, the basilar portion, or mid-body, and they can be non-displaced, displaced, or comminuted. So for these ones that are kind of mid-body and more displaced, that's when we get into referral for stabilization. So this area, it's under a lot of distractive forces from the quadriceps. And so typically we need to do some sort of tension band repair and really hold that together. The ones that are more apical or basilar, and they're small and they're non-displaced, they can be managed with rest. I would say this is a time you can't really bandage this area, and I wouldn't even try. The rest is just going to be your friend and keeping that dog as calm as possible. It's just a really challenging area. You can't really stabilize it, and there are a lot of distractive forces on it. So we can head to this slide, Matt. This is just that case that was referred to me. I think it was I want to say it was a 4-year-old German Shepherd or Malinois, some sort of that. It was running on the beach and running around chasing a ball, and all of a sudden came up lame. And so as you can see here in this picture, there is, I would say, I think the confusing part here is there actually isn't a ton of effusion. Everything is actually extra capsular, extra synovial. And so all of that inflammation is really coming from this kind of fracture. You can kind of see that fluffy area on the top of that patella. By the time I saw this was probably already about 3-4 weeks old. We continued to rest this dog. This dog did really well with conservative management and is now back kind of working with his owner. And so that concludes, we can go to that next slide, Matt. So that concludes really the stifle portion of this. We're gonna move forward to the hip and kind of go through a little bit of that. Seems like I've been talking for about 45 minutes. Okay, so I will try to speed up and kind of get through all of this. Some of the more important things obviously are kind of in this meat. So we'll move on to the hip. At this point, we'll go to that next slide, Matt, and we're really going to just cover these 3 things in the hip. So first off, we'll talk about a little bit about hip dysplasia. We'll then kind of get into luxation, and then we'll talk about some of these fractures. I would say again, this for me, when I get a potential, cranial cruciate ligament rupture or rule out hip, I tend to think of these dogs being a little bit more in this younger category. So we're still thinking in that kind of 18 months and younger range, especially for this hip dysplasia. Most often these dogs are definitely going to present to you by about a year of age. Luxations, I don't think those are extremely confusing to differentiate from a cruciate ligament. Those are pretty straightforward. And then similarly, the fracture, and more specifically, it's a slipped capital physeal fracture. Depending on timing of these and degree of displacement and things, sometimes can be confusing, but oftentimes are pretty straightforward as well. Just next slide, Matt. Moving into the hip dysplasia, again, we've got that multifactorial pathogenesis. We could talk about hip dysplasia for an entire lecture, but we're definitely not going to do that today. It's definitely a combination of genetics and hip laxity that plays the most important roles. Obviously, we have our breed predispositions. Definitely should be always on your rule out list. It's oftentimes can be confusing because early signs of hip dysplasia don't always show up radiographically. So even though they can have that hip dysplasia, if they don't really have those degenerative signs just yet, it can make things a little bit challenging when you just go taking a radiograph of these dogs. We can head to that next slide. Again, history is super important when talking about hip dysplasia. We think about this in these younger dogs. And so really when you have a dog that you suspect potentially may have a cruciate ligament that's on that younger side, I think it's definitely important to ask some more probing questions. You want to know acuteness of the injury. Again, cruciates tend to be a little bit more acute, while this hip dysplasia tends to be a little bit more insidious. And so has it slowly been getting worse? Those sorts of things. Again, this puppy jaw and internal rotation, that can sometimes lead you astray. So just make sure that we're really working out whether or not this is actual jaw or does this kind of have a stopping point. Again, going back to the video, which you will see again, and Matt, you can go to that video if you want, just of Boris doing that Ortolani sign again. I do tend to do this in a sedated animal. It just makes it a lot easier and a lot more accurate. And then lastly, we kind of move to radiographs. We can kind of go to that radiograph of the hips. And sometimes we can get lucky and we see this. I think this dog maybe was 18 months, something of that nature. And you can see that there is some subluxation of that femoral head. There's decreased acetabular coverage. There doesn't appear to be too many degenerative changes. There may be some flattening of that femoral head. That might be an early sign. But sometimes those radiographs can be a bit more nebulous. So again, really relying on that physical exam and making sure that we are palpating all of the joints in this dog. Just a quick kind of polling question is up next for you guys. In terms of kind of treating this hip dysplasia, what has been shown to be the most effective in controlling lameness? Just throwing that in there to make sure that everybody's still awake and with me. And where, anytime, I don't know how long it takes. Oh, interesting. All right, so we can head to that next slide. So actually, it really has been shown, the latest study is that exercise was the most important. So they did this study in 2013. It's actually out of NC State with Duncan LaSalle, but basically the duration of exercise was associated with a decrease in lameness. So it was about 60 dogs. It was a prospective study. They had dogs that exercised for less than 20 minutes a day, from 20 to 60 a day, and then greater than 60 minutes a day. They just looked at the presence of osteoarthritis and then the duration of lameness. And those dogs who exercised greater than 60 minutes a day showed lower lameness scores. Although I do love the fact that everybody did say weight, because weight is also super important. It does decrease the stress on this joint. And so that it is important, but really, according to this study, exercise is equally, if not more important. Again, for medical management, we get into this: weight control, exercise, supplements. nutraceuticals, and then I tend to move towards medications. Really for hips, I try to exhaust all medical therapy prior to moving forward with surgery. I don't think that we are as far as we need to be in terms of really surgeries that help these dogs very much. The other thing that makes it challenging is a lot of times we don't diagnose them early enough in order to do some of the more corrective things when they are younger. So I think early intervention with these medical things can be very, very helpful for these dogs. Moving again into some of that treatment things, surgical. And again, these are things that are most likely going to be referrals. So I'm going to go over these pretty quickly. Timing is everything. And I think for you guys as referring veterinarians, I think that is the most important thing. So the JPS, which is the symphysiodesis, is where we take that cautery to the middle of the symphysis, or the cranial aspect of that rather. We need to perform that prior to 18 weeks. And what that is going to do is that's going to increase the amount of femoral head coverage by closing that physis a little bit earlier. Then we move into these pelvic osteotomies, the triple and the double. That just depends on the number of cuts. Again, those animals can be up to 10 or 11 months, but once they reach skeletal maturity, typically we then move to a total hip replacement. And then lastly, severe cases that have gone on or they can't necessarily afford a total hip, we will do the salvage procedure of the femoral head and neck ostectomy. We can go to the next slide, which is just a couple of pictures showing these. And then here is a little bit of a case for you. I think this is one where I went down a rabbit hole. This dog is Smoke. This is not him, but his eyes are covered for privacy reasons. He's a 7-year-old male lab, intact. He was a very athletic dock diving dog. He had acute onset of left hind limb lameness, suspect cranial cruciate ligament tear. And that's pretty classic for the referral that we will get. So I'm already planning the TPLO surgery and putting this dog on the books even before it walks in the door. So it comes in, and I would say, minimal left hind lameness, not typically what I would see with an acute tear. So I'm not super pumped on that, but maybe I'm thinking, this is a partial tear. There is some joint effusion. Again, not a lot. Not a lot of appreciable cranial drawer, but there is some minimal tibial thrust. So I'm thinking at this point, I'm like, all right, this could be a very early partial tear. This owner is on it. This dog's super athletic. I did obviously palpate his hips in this exam. It wasn't something that was earth shattering, maybe some minimal pain, but really had decent range of motion. And so for me, I went, usually with these, you guys have already sent us radiographs, and I wait for surgical planning to really take our other ones. So I did take radiographs on this dog, and you can go to that next slide. This set of stifle radiographs, and you can see some effusion in this joint, but this fat pad is not displaced. This is not screaming, I have a cranial cruciate ligament rupture. There's maybe a little bit of arthritis, nothing too terrible. So I'm thinking maybe this is kind of an acute injury, but if you look towards the top, and then you can click that one more time, Matt, you do see this really ugly femoral head and actually kind of this fragment off. And that really, really took me by surprise. And so I went back and we did take the VD pelvis. And this is what both of his hips look like this. I thought I did here, just go one more slide down. And so when I looked at this, I was like, oh my goodness, cancel surgery, even though I hadn't told the owner that yet. But again, this is a little bit deceiving. And I think that, for this dog who had been very, very active its entire life, didn't really have some of those lameness issues kind of set in. He's just kind of dealt with this issue. So really at this point, I kind of transitioned into, a different treatment plan. Yes. Oh, I thought someone commented. And so we rested this dog. We did start a little bit of medical therapy, and it's back doing rest now. So again, just goes to show you, I can also get tunnel vision as well. And it's just something to keep in mind. We can go to that next slide. Didn't know if you guys had any questions at this point. If not, we'll continue to move forward.
Yep, we're all good right now.
All right, we'll keep it moving. So hip flexation, again, really not going to confuse this with a cranial cruciate ligament, but just some good information. Primary stabilizers of the hip is the ligament of the head of the femur, the dorsal acetabular rim, and then the joint capsule. So two of these need to be disrupted in order for that luxation to occur. The secondary stabilizers, the labrum, hydrostatic pressure, and then some of that musculature. For most of you, you will see that 75% of these luxations are in that craniodorsal direction. Clinical signs, again, not too hard. Lameness, pain on palpation of those hips. They don't really like extension. You can see shortening of that affected limb, again, because that cranial dorsal luxation. And oftentimes I'll kind of put their legs out and have a look at the level of their hock. And so the level of that luxated hock is always a little bit higher. The radiographs, obviously very, very important and helpful in diagnosing these. We can continue to move on, Matt. So treatment, usually we want to try to get in there as soon as possible and do closed reduction of these. And even before that, we want to evaluate the status of the joint and the status of the femoral head. Because if there is a fracture, if there is severe degenerative or are severe degenerative changes, that definitely will change the plan. Maybe closed reduction and Emer sling is not the best or is not the best option at that point. And we need to evaluate it. And you can see in this radiograph here that this dog did have a very small fracture of that femoral head. And so really closed reduction is not an option. But if for some reason everything looks great, femoral head looks wonderful, we can go ahead and proceed with that closed reduction. General anesthesia plus or minus a muscle relaxant. Have had some very good luck in reducing these guys, giving a dose of methocarbamol or diazepam to really relax them. Traction. So when you're prepping, when you're getting ready to get in there, make sure that your assistant or technician or anesthetist is providing traction on that leg. I've had a couple of dogs that even they replace themselves even as they're kind of prepping for me to come in. So that's important. Patience, definitely not a virtue of mine, but I do try in these cases. Hard part is that about 50% of these will reluxate. We don't necessarily know which ones. Treatment for these, if that closed reduction fails, open reduction and stabilization. There are many, many techniques, a capsulorrhaphy, prosthetic capsule. Again, these are most things that you guys are probably going to refer to us to save the joint. I'm sure a few of you do probably perform the FHO, but this is just a picture of a toggle we did the other week. And that's going to make the dog feel immediately more comfortable, and they tend to have a pretty decent success rate. Salvage procedures, again, the FHO, I'm sure some of you guys have performed those, and then replacement with the total hip. This is, I wish I could take credit, this is a beautiful FHO. You can proceed to the next slide. So this is just a dog that had bilateral. Again, the goal is to have no contact between the femur and the acetabulum. And rehab is the recommendation for that following surgery. So we're moving right through that hip. We'll now get into the slip capital physeal fracture. So really what happens during this fracture, it's really important for me and for these owners to really understand is that really it's the blood supply that causes so many issues. So we have basically a single extracapsular ring that then has a branch of these interosseous and intracapsular vessels. And so really, when there is a fracture of that capital physis, we then have damage to the blood supply, which then can cause subsequent resorption of that neck and some very major issues. And we can continue to move forward in the presentation, Matt. So clinical signs, again, most of them are young. So 90% of them are going to be less than 12 months old, again, because that physis is open. You will see some lameness and then oftentimes palpation of the hips. I think this sometimes has a biphasic lameness distribution. So oftentimes the initial injury, they can be quite lame. Then sometimes they do recover. So depending on their presentation to your hospital, you may see them in that super acute phase and easily diagnose, but depending on if they come a little bit later, you may not. So really what happens is that fracture happens, and then depending on the amount of displacement and the amount of necrosis that occurs, then you can have a period where they feel a little bit better, but then again, where they have a period of lameness from the femoral head or femoral neck necrosis. Typically, conservative management is not going to be successful. So moving along, Matt, we talk about primary repair, pinning of these. This is something that does need to be in the very acute phase. So we need to pin these almost immediately. And even still with pinning, we can sometimes get some neck resorption. And really, we don't know which dogs will do that. So we sometimes do have to come back and perform FHOs at a later date. So this is just an example of a dog we performed an FHO on, and then other salvage procedures where you salvage the joint would be a total hip replacement. Okay, we're getting there. So we'll move forward into the tarsus, Matt, here. Again, we'll go through a couple of these. Again, I think these are more easily diagnosed. These aren't things that you are going to commonly confuse with the cranial cruciate ligament, but just a couple of other processes that I just want to touch on today. The first one being the calcaneal tendon. We'll then kind of talk about luxation of the tendon of the superficial digital flexor muscle, and then plantar ligament disruption very, very briefly. So really for me, again, you can go to the next slide, Matt, sorry, is looking at these dogs and performing your orthopedic exam, because oftentimes in the tarsus, the angle changes significantly with the disease process. And so really we can kind of look at this animal and see these. So when we talk about the calcaneal tendon, a little anatomy is that it is made up of a kind of a group of things. So it's the paired tendon of the gastroc, the combined tendon of the gracilis, semitendinosus, and biceps, and then the tendon of the superficial digital flexor tendon. And there's kind of two pathogenesis of these. So you have a traumatic injury where you're going to have a more complete and acute problem. And then you have the atraumatic where you can have this partial kind of tear. This tends to be a little bit more insidious. And if we move to the next slide, there's a couple pictures of this. Again, these animals will have some degree of lameness, but it's more so their stance. With a complete, you're going to have hyperflexion of the joint with that plantigrade. And then with that partial, you will have that kind of moderate plantigrade stance. And you have, this is because that superficial digital flexor is still intact. And so you have that pull on that flexor tendon. This can be a little bit more challenging to interpret. So just kind of monitoring these dogs and making sure that you're doing that good, complete orthopedic exam is going to be important. Sometimes these guys will have swelling, especially in an acute tear where that tear happened. So that's good to put your hands on the dog and make sure you evaluate that. Treatment is most often surgical referral, especially in these complete dogs. I would just say, just to note, this is a pretty financial investment, and it's also a time investment as well. We do need to surgically repair the tendon, but we also have to immobilize the joint. And so oftentimes this will necessitate a second surgery when we move forward in the progression of healing. So we can go to this video here, Matt. So I actually, early on, I was kind of fooled by this one. If you kind of see this skipping lameness, it's a little intermittent, it's mild. This dog doesn't seem too affected by it. It almost kind of looks like a medial patella luxation. And so this is one that's kind of a little bit easier to miss in, and why a orthopedic exam is important. And so we can go to the next video, which is luxation of the tendon of the superficial digital flexor muscle. And so as you can see in this video, as he kind of rotates this leg and pushes on that superficial, you can see it kind of pop over the point of the hock. And so that is just a luxation of that. It's typically a little bit more lateral due to the disruption of the medial retinaculum. They can have some swelling associated with it. And again, you will see that intermittent lameness. Surgical correction for this is actually, if we go to the next slide, quite straightforward. Basically, what you want to do is imbricate the tissue on the side that the opposite the side of luxation. So you're really just tightening that up. These dogs typically do very well, have fairly minimal complications. I would say the hardest part is just keeping these dogs quiet during the rehab period. Lastly, we'll get into this plantar ligament disruption. Again, these dogs are they're decently lame. They can have a little bit of intermittent lameness depending on the degree, but they will definitely have some subluxation of the joint. And we can continue to move forward, Matt. And it's that proximal intertarsal joint. There is this breed predisposition in collies. So if you have a dog that comes in that is a collie and does look like they have a little bit of a weird plantigrade stance, this would be something that would come into my mind. You can also have this being a traumatic injury as well. And I've seen that before as well, but oftentimes it can be more of this chronic kind of degradation of those plantar ligaments that lead to this. If that's the case, oftentimes this will be bilateral. Moving on to the next slide, pretty much again, orthopedic exam and observation. So clinical signs, want to make sure we measure the angle of the joint. Traumatic form in the collies, they often aren't painful just because they've learned to adapt, but we do sometimes take these stressed views and you get that dorsiflexion of that. This is extremely pronounced. I would say most often it's not going to be that pronounced. Moving forward to treatment of this, treatment is basically arthrodesis of that calcaneal quartile joint, or what we call a partial tarsal arthrodesis. We can do it with a single screw. I would say more often and more stability is this plate, laterally placed plate, again, surgical referral for that. And we've just got this one last thing, and then we'll move into questions if anybody has them. If not, we'll get you out of here. But keep moving forward into this miscellaneous is going to be the iliopsoas muscle injury. So it is typically an acute and athletic injury, but it can sometimes have a chronic progression to it. I would say for me, this is more so a rule out diagnosis, and not typically one that I really strongly make on physical exam the first time. I feel like a lot of times I see these dogs, and unless they're crying out in pain when I palpate that iliopsoas, sometimes I think it can be decently challenging. It's not as common of an injury, and honestly, I think it's as we've become, more dogs have become athletic and sporty in their agility and things. I think it's an injury that we have seen more commonly more recently. So this is it's a muscle tendon junction. And so basically the iliacus muscle and the psoas major. So the iliacus comes from inside the pelvis, and that picture may be a little bit small. I apologize for that. And then the psoas actually originates from underneath the spine, and then they insert on the third trochanter on the inside of that femur. And so typically that injury does occur at that muscle tendon junction. Again, talked about agility, changes in direction. These are types of things that you will see. Moving forward, Matt, in clinical signs, again, lameness, like I said, if it's an acute injury, oftentimes they can be pretty painful. Chronic injuries, they may be a little bit less painful, and they may have a little bit harder and more nebulous kind of lameness with it. They can have some pain on palpation. Again, I would say those more acute phases of the injury, those dogs will light up. The chronic ones, I think they learn to adapt a little bit more. Imaging for these guys, radiographs are usually unrewarding. I pulled this one from the internet, so you can sometimes see a little bit of mineralization. I'd say that is not the norm. Ultrasound, I probably would leave that up to an ultrasonographer. I for sure would not be comfortable ultrasounding that iliopsoas, and then some advanced imaging. And then moving along into treatment, I would say most often we try to manage these conservatively. So that's going to be rest, that's going to be non-steroidals, that's going to be laser therapy, and then controlled rehab. And it may be extended. I mean, these dogs can sometimes, again, because it is a muscle tendon junction, have prolonged rehab. So you're kind of getting into that 6 to 8 week mark, sometimes at 12. I would say we don't typically do surgery on this unless these animals are very, very refractory to that conservative management. And in those cases, we will cut the tendon of insertion, and we can do that. Those dogs do recover and they tend to do well, but athletic capacity and potential is definitely decreased. So that is it. I know the last few slides were pretty quick, but just want to thank you guys for your attention. Thank you, Matt, for kind of running the presentation. I am happy to take any questions. I also want you guys to also think about what you want to learn next year. Hopefully they did save the best for last and for this year, so you guys enjoyed the talk, but I'm happy to answer any questions. And also, you know, if you have them tomorrow and you want to call me, I'm there as well. But thank you.
We do have one question. Thank you, Dr. Taylor. And thank you, Boris, for volunteering his time.
Yes, and this is Boris and this is Roger. Roger's the Shih Tzu and Boris is a little Frenchie.
Dr. Stuber is asking, do you ever utilize intra-articular steroid injections for any rear leg lameness? And if so, which situations?
I typically do not, is the short of that. And I think for definitely not in the stifle. I think the majority of intra-articular inflammation and in those are due to cranial cruciate ligament ruptures. And so stabilizing those dogs are what is going to control the inflammation and make those dogs feel a lot better. If we're talking about a disease process like immune-mediated polyarthritis, I typically would go with more systemic steroids than I would intra-articular steroids. It's very interesting to hear that come from my mouth too, being an equine surgeon as well, where we use those all the time. But I typically do try to minimize my usage in dogs. Now, I do think there absolutely is case for hyaluronic acid. They've been studying that a little bit more frequently, and then some PRP. I know that they've definitely done some studies in that, predominantly in the stifle, for partial tears. And so I think they've had some decent success, but steroids, not a lot. But that's a great question.
Thank you. Another one here. We do have some more popping up. I know you're a surgeon, but what are your feelings on laser?
Yeah.
How do you use it, if at all, and what manufacturer do you use?
All great questions. I do like laser. I like it more from its anti-inflammatory and healing perspective in terms of post-operative and wounds. The hard part for me is that a laser is not strong enough to repair a cruciate ligament if we're talking about that. And a laser, in my opinion, is not strong enough to replace a patella. But I will say it can decrease some of the inflammation. But I think what we're looking at more so is, what is the primary problem? If the primary problem, is surgical in nature, the laser is only masking a little bit of that inflammation. I think getting to the root of the problem is more important. In terms of manufacture, that is a great question for our surgery manager, because I do not know that answer, and I apologize for that. But if you send me an email, I will happily give you the one that we have. And I do absolutely think that it has plenty of benefits and is very useful to have in your practice.
Thank you. Another question. Saying thank you, and then can you describe the movement associated with the Orlani reflex again? I either learned it or I completely blocked it out.
Oh yeah. Hey Matt, could you pop that video up again? Is that possible? And you tell me. So if he has that video. So pretty much what you want to do is you kind of want a limp leg, which is a little bit hard, which is why I do this in sedated animals. It's hard to evaluate when you look at Boris there because he's tight as a tick. He's not helping me. But so what you're going to do is you're going to place your thumb on that greater trochanter of the femur, and then you're going to apply. So if you see, my right hand is applying a dorsal force, like pushing up against that greater trochanter. And so in doing that, I'm applying, putting that joint in a little bit of dorsal luxation. And so what's happening then as I abduct, so I'm lifting the leg away from the body and then listening or kind of trying to feel a click. And if the femoral head goes thunk, that's what I am listening or feeling for, then that is considered a positive sign because they have hip laxity. Does that make more sense?
I think it does.
Okay.
This is a good question because this is owners finding out their own treatment plans online. Have you had any clients wanting to utilize a hock brace to treat a CCL injury? I've had 2 clients find them on Amazon, and they were needing, they're asking if they should use it as a brace.
So I don't know, but maybe this is, so I actually did recently, it makes me laugh because obviously it's a cranial cruciate and they have a hock brace, if that's what you're asking. And I'll touch on stifle braces as well. But yes, I have had recently 2 clients, and it is quite funny. I think maybe there's more of a placebo effect for them than anything else. But no, does it provide stability, a hock brace for the stifle? It does not. Stifle braces, are tough. Again, for me being a surgeon, I want to fix the problem. Now, I did recommend one in a patient today. It was a 12-year-old German Shepherd that had a lot of comorbidities in terms of some IVDD and some other things that I don't think surgery was probably the best thing for this animal. So I do think that they provide some sort of support for a short term. I tell people that if that's the case, wear it when potentially the dog is most active, and then take it off when they are not, they're laying around, just because sometimes I think we can get some skin issues and things that, I don't really, and you guys probably don't want to have to manage.
One question here, are there any good orthopedic textbooks out there for reference? Actual textbooks rather than online references?
Yeah, in terms of like surgical procedures, I guess, oops, sorry. There are, the surgery book that is used for our board examination is Tobias and Johnston. I think that probably is a little bit too much detail if you're just kind of wanting to scratch the surface. I think Fossum is a better resource. And there is, I want to say there's a new-ish edition of that out. But that's I think provides some good pictures as well in that. FOSSUM. FOSSUM.
Thank you. This one's from Dr. Nystrom. I'm not going to ask you the second half because he is trying to fluster you. Dr. Nystrom and Dr. Taylor work side by side most days of the week. But he is asking, do you like to use steroids to treat arthritis?
No. Like systemic steroids, I do not. I typically stick with non-steroidal anti-inflammatories. I do, in general, I find that carprofen is probably the most effective. I think that that's purely anecdotal and probably just because it's my favorite. When we talk about long-term complications and if patients are on these for long periods of time, I do think that potentially, a Galliprant or a Previcox is probably a little bit safer, but no, Dr. Nystrom, I tend to shy away from some steroids for systemic arthritis.
I have a question. So if you have one that's not responding that well to Novox, what's your typical second choice? Or like, would you then jump to like a Galliprant because you're probably thinking it's going to need to be long term anyway?
I would actually probably move towards other modalities. So I would do more like alternative therapy in terms of trying to see a rehab specialist to see if we can't work some of the other issues out. So doing some more acupuncture or maybe some more alternative things in those cases. Sometimes that does not work. I would add in probably gabapentin. You could try some, see, if Galliprant or those things work, obviously with an appropriate washout period.
Are there any other questions out there before we officially start wrapping it up? Those are all great questions. Thank you.
Yeah. And I appreciate you guys' attentiveness here. And then again, just a plug for Vets Pets and just thinking about what you guys would like to learn next year. I know that we have quite a few people that enjoy giving these talks. So we are here to answer your questions and kind of guide you in any way that we can. And just feel free to email those suggestions to ce@thevetspets.com.